start today's session. We have 3 topics today, and Dr. Nazeer has refused to introduce, so I guess now by the time we know each other. We are going to discuss 3 topics today: typhoid fever, acute cholecystitis, and malabsorption syndromes. And the purpose is just to give you a brief overview. You must have a lot of experience in typhoid fever, acute cholecystitis, and not going to go in detail in malabsorption, just to give you the causes and main overview. Objective of today's session: by the end of session, the participants should be able to know the clinical presentation, diagnosis, treatment of enteric fever, clinical presentations of acute cholecystitis, and know when to refer and when the patient needs admission to the hospital. Mechanisms, causes of malabsorption, and clinical presentation of malabsorption syndromes with general principles of management. Let's take typhoid fever first. This is a verse from Sobin, who wrote this in 1934. In typhoid, gut changes are found, great patches of Peyer profound, have cell infiltration, and then ulceration, from which salmonella abound. So it just briefly gives you the pathogenesis of salmonella. So what is salmonella? It's a bacteria, and it causes typhoid fever, and 16 million people are affected annually, and it causes 6 lakh fatalities. And it has evolved the ability to spread from the intestine to other organs and cause a systemic infection. More discrete definition, it's an acute febrile systemic illness. With systemic mean when the whole body is involved. It's not a localized infection. It is usually caused by a motile gram-negative bacilli, and which could be Salmonella typhi or paratyphi. Now the question comes, what's the difference between enteric fever and typhoid fever? Enteric fever is a syndrome which involves constellation of sustained fever, headaches, abdominal pain, splenomegaly, leukopenia. And when the enteric fever is caused by Salmonella typhi, it is called typhoid fever. Okay, the geographic distribution of typhoid. Where do we stand? And you can see here in the green, which denotes the area of high endemicity. So in the subcontinent area is a highly endemic area. And the importance of this multi-drug resistance is that it has emerged basically in these regions. And what it poses difficulties, we are going to discuss it in the treatment. What's the epidemiology? Basically, it's an infection which is spread by breach in the sanitary controls. That is, when the food or water is contaminated with sewage or with the fecal material. And the bacteria has got a high specificity for human host, in contrast to other salmonella which are transmitted from animals, which cause acute gastroenteritis-like syndromes. There are 5 F's we traditionally learn in our medical schools in its transmission: food, fingers, flies, fomites, and feces. So basically these 5 factors are involved in its transmission. What are the symptoms? The symptoms are usually non-specific or generalized symptoms. Sustained fever, headache, diarrhea or constipation, anorexia, vomiting, abdominal distension, cough, and apathy. Sometimes patient may have slight sore throat and may have some productive cough. Lymphadenopathy is usually not seen in typhoid, but as an organism it can cause lymph node enlargement. What are the signs? Fever. Almost like 90 to 95% of patients have fever. Abdominal tenderness, especially right lower quadrant tenderness. Splenomegaly, hepatomegaly, relative bradycardia. Relative bradycardia means that with every rise in temperature, with every 1 degree rise in temperature, the pulse rate should increase by 10 beats per minute. So if a patient pulse is like 70 baseline and his temperature is like 103, so at least you expect that the pulse should be 120 beats per minute. So if the patient's pulse with a temperature of 103 degree Fahrenheit temperature is 90, it's a relative bradycardia. The relative bradycardia is not specific for typhoid. It can occur in other infections which are intracellular, like Legionella, like viral infections, like hepatitis A. Rose spots, these are like petechial spots seen on the trunk in the first week of illness. And on auscultation, rales or bronchi can be heard. And the other signs are like epistaxis, meningismus. The infection can be fatal and the patient may appear delirious, drowsy, in shock, or even in frank meningitis. This is a rose, and these are the spots on the rose. But the rose spots are different. They are rose colored, like red colored spots on the trunk, and these are non-blanching, like petechial. And these are very pathognomic, and even if you do the biopsy and culture it, 2/3 of the patients will grow salmonella out of these spots. Okay, this diagram is showing clinico-pathological correlation in typhoid fever. There are 5 phases. Period of incubation, which usually is 7 to 14 days. Then there is a stage of active infection in which there is a rising fever pattern, which in other words we call step ladder pattern. After that, the fevers become sustained and remittent, that is, the daily fluctuations are minimal. And this stage is called fastigium stage. After this stage, then the fever declines and then the patient enters into a stage of convalescence. Okay, this is important. Blood cultures, if you do in the first week of illness, they are 80 to 90% positive. While the stool and urine cultures, they are usually not positive at this stage, but they do become positive in the later weeks of illness. Widal test, which is the most commonly ordered test in typhoid, in the first week of illness you can see that only 20% of patients are positive. And what is the clinical significance of Widal, we'll discuss in the laboratory investigations. Okay, how we are going to investigate a patient with typhoid? First thing is CBC. What we are looking in CBC is basically leukopenia. In typhoid fever, there is usually no leukocytosis, but on rare occasions, leukocytosis can occur. And the other thing significant is that 2/3 of the cases, there are no eosinophils. LFTs, this is an infection which involves the reticuloendothelial system, like bone marrow, spleen, liver. So you can see slight elevations in ALT, AST, and slight elevated alkaline phosphatase, and a slight rise in bilirubin. Urinalysis, like all febrile illnesses, it can cause proteinuria, pyuria, and sometimes casts also. And the severe infection can lead to disseminated intravascular coagulation. Okay, stool analysis is important as it can reveal mononuclear cells. Okay, culture is the most important step in the management of typhoid fever, as all other tests, they are not highly sensitive nor specific. Blood cultures, if they are done in the first week of illness, as we saw, they are like 80 to 90% positive. And the textbook says that if they are combined with urine and stool cultures in the first week of illness, they can clinch the diagnosis in 90% of patients. Stools usually we don't do, but in combination the sensitivity increases. Bone marrow cultures, they are significant because we know the rule that if the patient is taking antibiotics and we culture, then antibiotics suppresses the growth of the bacteria and the cultures don't come positive. But the culture of bone marrow is important because even if the patient is on antibiotics for the last 5 days, bone marrow cultures can become positive. Rose spots, if you are lucky enough, you catch the rose spots, you do a biopsy and culture those, it will grow Salmonella in 2/3 of the cases. Okay, some principles about cultures. They should be obtained before initiation of antibiotics. And multiple blood cultures, they are even sensitive in some series in 97% of cases. And the bone marrow cultures may be positive when blood cultures are negative. Stool and urine cultures, they are less frequently positive, and rose spots, we can do those cultures also. Okay, Widal test. What do you think about Widal test? How sensitive this test is? If we do Widal test on 100 patients of typhoid, what do you think? How many percentage of patients will have a positive Widal test? Yeah, the sensitivity is pretty low, in 40 to 50 range. And the other thing is, how do you interpret Widal test? Because our area, right, our area is highly endemic area, as we saw in the map. So we are probably exposed to Salmonella, and in addition, the other non-typhoidal Salmonella cross-react. So the antibody which are detected in the Widal test, they may be secondary to or a reaction to a non-typhoidal Salmonella, or even due to some other Enterobacteriaceae, some other gram-negative rods. So that's why this antibody rise is not specific. The only thing is if it's a 4-fold rise in the acute and the convalescent stage. But if you wait for the convalescent stage, it will take like 2-3 weeks, and you have to decide early. So that is not helpful to make a clinical decision. Okay. Then there are other rapid diagnostic tests, and in Pakistan we usually do Typhoid. Typhoid detects antibodies to typhoid antigens, IgM and IgG. There are various studies, and the sensitivity ranges from 53 to 93%. And in one study, the sensitivity was like 79%, while the specificity was 89%. We see every day that the patients who do not have typhoid, they are positive for Typhoid. And the patients who have typhoid, they may be negative for Typhoid. So it's not a very sensitive and specific. You have to combine it with clinical picture. If a patient clinical picture is consistent with typhoid, even if its Typhoid is negative, you are going to treat it as a typhoid patient. So the researchers, they continue to search for the ideal rapid test to diagnose acute typhoid fever. This is a picture of terminal ileum, and you can see that the mucosa is diffusely inflamed along with some purulent exudate. And this is a ileocecal junction, and you can see these spots. These are the Peyer patches which have become proliferative or hypertrophied, and in the later stage they will ulcerate. And this is a close picture of a Peyer patch, the lymphoid tissue in the terminal ileum, and you can see that like a fungoid mass, they have hypertrophied and with some necrotic material in it. Okay, points about carrier. Once a person is acutely infected with typhoid, then 1 to 4% of individuals in endemic settings, they can be chronic carrier. And what is chronic carriage? It is persistence of Salmonella in stool or urine for more than an year. And the persons who have abnormalities in their biliary tract, like gallstones, they act as a persistent nidus of infection. And rarely the carrier state can be in the urine if they have, And the typhoid carrier state is an independent risk factor for carcinoma of the gallbladder. It could be an MCQ in your MRCGP. Urinary carrier stage is rare and usually occurs in patients who have urinary stones or prostatic hypertrophy. And the point here I want to emphasize is that the chronic carriers, they often have high serum antibody titers against the VI antigen. So if you do a Widal test, then the carrier patient will have a high titers to this antigen. What's the treatment? The treatment is complicated by multi-drug resistant strains. Initially, the Salmonella typhi was sensitive to ampicillin, Ceptron, or trimethoprim sulfamethoxazole, and chloramphenicol. But over the years, it has acquired resistance, and this has led to a shift toward the fluoroquinolones and third-generation cephalosporins as empiric treatment for typhoid fever. Why quinolones are preferred? Basically, there are 3 points. One is that these are bactericidae as compared to chloramphenicol, which is a bacteriostatic. They are concentrated intracellularly. Salmonella typhi is an intracellular bacteria, and this is also concentrated in the bile. And they result in more rapid effervescence, that is clinical resolution, than the beta-lactam agents. But unfortunately, there is a decreased susceptibility to quinolones, especially ciprofloxacin, and especially in our area. So what are the antibiotic regimens we are going to use to treat typhoid patients? In adults, the current recommendations are that you use fluoroquinolones as ciprofloxacin 500 BD or ofloxacin 400 BD orally or parenterally for 7 to 10 days. Or you can use a third generation parenteral cephalosporin like ceftriaxone 2 to 3 grams OD for 7 to 14 days. In our hospital, usually we see patients when they are in a toxic state and they have used oral antibiotics. So usually we start them on 3 grams of ceftriaxone. Or outpatient, you can also use oral cefixime 400 BD for 7 to 14 days. So here the duration is like 7 to 14 days. So how you are going to decide whether you are going to stop at 7th day or at the 14th day. So basically the decision to stop antibiotics is clinical. What does clinical mean? That if a patient, you start antibiotics and in 2nd or 3rd day his fever is down, he's clinically improved, doesn't look toxic, at the 7th day you can stop antibiotics. But on the other hand, if a patient clinical resolution took 5 days, 6 days and he was very toxic, in that patient you might prolong the course to 10 or 14 days. In children, you can use ceftriaxone, cefotaxime, cefixime. Usually we don't use quinolones in children because of toxicity to the cartilage. But over the past 10 years, we have enough data that if we have to use ciprofloxacin, usually doesn't cause that toxicity. So in rare circumstances, if you are dealing with a resistant bacteria, you may use fluoroquinolone. The important thing is that the bacteria is susceptible or not. If it's susceptible, then you can use these old drugs, chloramphenicol, amoxil, or trimethoprim sulfamethoxazole. How do you treat chronic carrier stage? Usually you treat for longer duration, and this is with either ciprofloxacin or ofloxacin, and you treat for 14 to 28 days. The other...
how do you decide that you should use for 14 hours? Because it's a carrier stage, and there are
Yeah, basically the duration is from studies. Some studies have shown that 14 days treatment is enough. So ideally you should treat it for 28 days, and then after a week or 10 days you can do cultures to see if that has eradicated the carrier state. The other point is diet and activity. Diet is very important because patient in a toxic state is not eating, so you don't want to restrict the diet. You may use soft diet if he is having any or severe abdominal symptoms like diarrhea, tenderness, but don't restrict the diet unless there is a complication. Activity, disease is marked by severe fatigue and weakness, which even persists after the patient has cleared the illness. So bed rest and avoiding of exertion is very important. Okay, as a family practitioner, this is very important to know that when to refer the patients. If a patient is looking toxic, he might be needing parenteral antibiotics. or if a complication has developed like intestinal perforation, GI bleeding, or a patient has become delirious or has gone into shock. If patients who are immunocompromised or with multiple comorbid conditions like renal failure, CHF, COPDs, liver failures, and non-responders, the patients who we put on antibiotics and they are not responding or they are deteriorating, then that's an indication to refer to the hospital. How do you prevent it? There is a simple rule which is usually for travelers, but basically it says boil it, cook it, peel it, or forget it. So if you cannot use anything besides these, it has a risk that it can transmit Salmonella typhi or enteric pathogen. The other way to prevent is vaccines. There are two types of vaccines. One is oral and the other is intramuscular. This is more common. The oral one is a new one, which is an attenuated strain. So you cannot use this strain in immunocompromised patients as well as children younger than 6 years. The oral strain needs a booster dose after 5 years, while the intramuscular vaccine, it needs booster every 2 to 3 years. And this is given in a deltoid 0.5 ml. But the point to remember is that neither of the two available vaccines provides protection against paratyphoid fever, and neither is completely effective against Salmonella typhi. So even if the patient has been vaccinated properly, he may have enteric fever, but it's going to reduce the incidence. So that's why caution in what is ingested remains warranted. Okay, let's take acute cholecystitis. It's basically a topic which we are going to discuss in surgery, but let's review quickly. It's a syndrome which involves right upper quadrant pain along with fever, leukocytosis associated with gallbladder inflammation, and gallstone disease. So these 5 things are important in the clinical presentation of cholecystitis. This diagram shows pathogenesis, and you can see that this is a gallbladder. It contains gallstones, and when they move out, because the cystic duct is narrow, a large stone can get impacted here. And if this stone gets impacted distal to the pancreatic duct, like here, then the patient will develop pancreatitis and as well as obstructive hepatitis. So this is important. The first step in the pathogenesis is a blockage of the cystic duct. But this blockage alone doesn't cause acute cholecystitis. This is inflammatory or irritation of the mucosa due to gallstones that initiates the inflammatory cascade, and the prostaglandins play an important role. And that's why NSAIDs has a preferred role in pain control, because they are prostaglandin synthesis inhibitors. These are the pictures showing various stages of acute cholecystitis, and you can say this is an swollen gallbladder with the hemorrhagic spots on it. And here you can see that it has become edematous, and here the color has changed, and this gallbladder is becoming gangrenous. On physical exam, usually the most important thing is right upper quadrant tenderness and Murphy sign. Sometimes you can feel the globular gallbladder here, and this is a diagram picture showing elicitation of the Murphy sign. What is Murphy sign? You put your hands at the lateral 2/3 and medial 1/3 where the gallbladder is, slightly press and ask the patient to take a deep breath. With the diaphragmatic movement, the gallbladder moves down, and as it hits the fingers, then the patient suddenly feels pain and he holds his respiration or breath. So this is called a positive Murphy's sign. What are the differential diagnoses? Basically, differential diagnosis is broad, as you can see from the list. Cholecystitis is the main right upper quadrant. Hepatic causes like acute hepatitis, cholangitis, hepatic abscess, pancreatitis. Acute cholecystitis can also cause pain in the epigastrium. Appendicitis, sometimes there is a retrocecal appendix which is high up, and in that case patient will present as if he's having acute cholecystitis, but when it is opened up it is actually an acute appendicitis. Basic peptic disease. The other thing is right lower lobe involvement, either with infarction or pneumonia. It can present with right upper quadrant pain. Sometimes costochondritis. If you press the ribs, patient will feel pain. And herpes zoster, the typical rash is preceded by dermatomal skin pain in this area. This is an ultrasound, and you can see that the gallbladder is markedly distended, has become globular, and the wall is thickened, and there is also a pericystic fluid collection consistent with acute cholecystitis. This is a HIDA scan, which is a technetium labeled scan we use to diagnose acute hepatitis when the ultrasound is not very helpful. And you can see that in this the gallbladder is black, it's getting the technetium, but in acute cholecystitis the gallbladder will not take the technetium. The other thing you can do is a CT scan, but ultrasound is a cheap and very effective way, so usually CT scan is not done, but here you can see that the gallbladder is distended with thickened walls. Laboratory investigations. The first thing is CBC, that may suggest that patient has acute inflammation, and you can see leukocytosis with neutrophilia with left shift. And Dr. Azimullah knows better what is the right shift, so you can ask him after the lecture is over. That reminds me a joke that a doctor's brain has two parts, left and right. In the left there is nothing right, and in the right there is nothing left. So the other things you can do is LFTs, and because the pathogenesis of the acute cholecystitis is impaction of the stone and the back pressure, so alkaline phosphatase is raised more than the SGPT. So it is more like an obstructive picture than the hepatic picture. And if the stone is impacted distal to the pancreatic duct, then the patient will also be having acute pancreatitis, and you will get raise in the amylase and lipase levels. Okay, what's the treatment? Usually the acute cholecystitis needs hospital admission, but if you see the patient in the clinic, what you're going to do? The first thing is hydration. If the patient has been vomiting or intake is poor, you can stabilize the patient by giving a ringer's lactate or normal saline. Make the patient NPO, make sure patient has received a good analgesia, and the NSAIDs are preferred because the prostaglandins has a role in the pathogenesis. So NSAIDs block the prostaglandin, and that's why they are better for it. Especially you will see patients who will come to you with 2 to 3 hours history of right upper quadrant pain, and then it gets relieved. Then after 4 or 5 days they have the same attack. So they are having biliary colic. They are not yet developed acute cholecystitis. So in that case, the pain control NSAIDs are better. The other things are antibiotics. Most of the time the acute cholecystitis is associated with infection, and the usual organisms are E. coli, Enterococcus, Enterobacter, and Klebsiella. For IV, M and Gent is the preferred regimen, but you can use other antibiotics which covers gram-negative organisms. If it is a complicated case like gangrene or emphysematous cholecystitis, then the anaerobes might be playing a role in it. So in that case, you have to cover anaerobes either with clindamycin or flagyl. This is a flow diagram showing what do you do if you encounter a patient with acute cholecystitis. Basically, this is what happens in the hospital. That after the admission, they are evaluated for surgical risk. If they are a high-risk patients and they are clinically improving, they are managed conservatively. But if they are deteriorating, we don't operate. We just do a percutaneous cholecystostomy, which is we just put a tube in and make a hole in the gallbladder and relieve the pressure out of the gallbladder. In the low-risk patients, if they are deteriorating, the patient will get an emergent cholecystectomy. But if they are improving, then you will continue the supportive management and do an elective cholecystectomy later on. Prognosis, it's important to know, mortality is less than 1% in young, healthy patients, but it approaches 10% in high-risk patients or elderly patients. What are the complications of acute cholecystitis? You can see this is a normal gallbladder. It becomes gangrenous and now it has perforated, and you can see that all the perforation has spilled into the peritoneum, and this patient comes with acute peritonitis. Other complications are like emphysematous cholecystitis, which is actually a gas in the gallbladder wall, and the patients who are immunocompromised or diabetics or elderly, they are at higher risk for this complication. The other complications are they develop a cholecystoenteric fistula or a gallstone ileus if this gallstone pass into the intestine. Malabsorption. What is malabsorption? It is a term which encompasses defects occurring during the digestion and absorption of food nutrients by the GI tract. So either if the digestion is impaired or the absorption from the mucosal surface is impaired, it's going to lead to malnutrition. It could be global, it could be partial. Global means that many nutrients are not absorbed. And partial malnutrition means that only single nutrient is not absorbed, like pernicious anemia, in which only vitamin B12 is not absorbed. So there are three phases: luminal phase, in which there is a digestion; mucosal or absorptive phase, this is from the mucosa; and post-absorptive. After they are absorbed, they are going to get transport to the blood via lymphatics. So any disease which affects these stages is going to impair the absorption. This is a diagram going to go quickly. Protein digestion. When we eat proteins, they are churned in the stomach with the acid pepsinogen. When they come to the duodenum, the pancreatic enzymes are secreted like proteinases. Other enzymes that are secreted are lipases for fat and amylase for carbohydrates. And after the proteins are broken down into simple amino acids, they get absorbed here, as you can see in this diagram. So this is the mucosal phase. If there is a deficiency of peptidases, proteinases, then the patient will have a mucosal cause for the malabsorption. This is a diagram showing fat digestion. The fat should be emulsified first. So that is done by the bile salts, which unite with them and break down and emulsifies them. Then the pancreatic lipase, they act on those emulsified droplets and then break down into free fatty acids and monoglycerides. That is at the lowest level. And these are then absorbed from the mucosa. And again, in the intestinal cell, they form chylomicrons, and through the lymphatics, they are entered into the blood. So this is a luminal phase. If the person is having cirrhosis or obstruction, he's not going to secrete bile into the lumen. So there is no emulsification. So all the later steps will get affected and the fats won't be absorbed. If there is enough bile but there is no lipase, then it means this is again a luminal cause. Then it won't, the fat won't be broken down into smaller elements and they won't be get absorbed. If there is a problem with the mucosa, it's damaged, or there is a villous atrophy, or in the cell they are damaged by tuberculosis or lymphoma, they are not going to get absorbed and transported. So this is a mucosal phase. So this is basically a chart, not going to go in detail, but basically these are the luminal causes. And you can see inadequate gastric mixing, especially after surgeries, insufficient digestive agents, whether it's due to pancreatitis, due to liver disease, due to biliary obstruction, they are going to impair with the absorption. Or improper milieu, like Zollinger-Ellison syndrome, in which there is a hyperacidity in the stomach and it is transferred to the duodenum, and that interferes with the pancreatic enzymes. The other thing is mucosal, which is acutely abnormal epithelium or chronically abnormal epithelium. Acutely, mostly in infections like Giardia lamblia, and in chronic celiac disease, which is a disease which is due to the hypersensitivity to the wheat, which contains a protein which is called gluten or gliadin. So the patients develop antibodies, and whenever a patient eats gluten diet, that antibodies react with it, causes inflammation and destroys the intestinal mucosa, resulting in impaired absorption. And then there is an impaired transport, whether it's due to congenital lymphangiectasia or blocked lacteals because of lymphoma, tuberculosis, amyloidosis, etc. Okay, it's important to know the clinical features so that you can diagnose and properly treat and refer these patients. Okay, the first thing is osteoporosis. Especially, we know that vitamin D is a fat-soluble vitamin. So if a patient is having fat malabsorption, it's going to be low vitamin D. And if any disease of intestine, even in celiac disease, the calcium will be low. So these patients are prone for the pathological fractures, hypocalcemia, protein malnutrition, and calorie malnutrition, like wasting a lot of fat, proteins, carbohydrates, is going to cause weight loss, and the patient will be emaciated. Hypocalcemia can cause tetany. Then there is pigmentation, especially with celiac disease. There are a lot of skin pigmentations like dermatitis herpetiformis, eczema, and the other pigmentations. Abdominal distension, usually it's associated with malnutrition, and you must have seen pictures of children with pot belly and thin limbs. Basically, why abdominal distension occurs is hypokalemia causes ileus, hypoproteinemia, it causes ascites. And especially in malabsorption syndromes, because of malabsorption, the bacteria act on carbohydrate fats and cause a lot of gas, flatulence, and abdominal distension. Ecchymosis, if there is a vitamin K deficiency, and steatorrhea with fat maldigestion and absorption. With protein malnutrition, there is hypoalbuminemia, and patients may have edema. With vitamin B12 deficiency, they may have glossitis, cheilitis, stomatitis, and with diarrhea, they might be dehydrated or even have metabolic acidosis. Laboratory investigations, so all those nutrients which are not absorbed, they can cause a sequelae. So in CBC you can see anemia, macrocytic with B12 deficiency and microcytic with iron deficiency. You can do B12 folate levels, you can do prothrombin time to see vitamin K is absorbed or not. Electrolytes to check if they have hypomagnesemia, hypocalcemia, hypokalemia. Serum protein and albumin are low due to protein malnutrition, and because of malnutrition, the cholesterol and triglyceride are also low. Anti-gliadin and endomysial antibodies, usually to diagnose celiac disease. And you can also do stool analysis to see if it contains undigested food particles, protein fibers, fat globules, and also to check for protozoa like cysts for Giardia lamblia. Imaging studies, small bowel series are done. These are usually done if you refer the patients to a gastroenterologist. What you can do is you can do a plain X-ray abdomen. Sometimes chronic pancreatitis presents with calcifications, which you can detect on the plain X-ray abdomen. Test for fat malabsorption. The ideal test is 72-hour fecal fat estimation, and the normal range is less than 6 grams fecal fat per day. And the other thing quickly you can, in the lab we can do is to stain with Sudan, and this is a stain. You can see that the fat globules are stained with it. These are the specialized tests to detect what type of malabsorption it is. This is desallosis to detect mucosal integrity. Hydrogen breath test is for carbohydrate malabsorption, and the CO2 breath test for bile salts, and the Schilling test for B12. Upper and lower GI endoscopy can be done by the specialist with biopsies that can clinch the diagnosis. And one recent thing is capsule endoscopy, and this is a capsule with a camera. So patient takes this capsule, and as it goes through the intestines, it can take pictures, and you can see these are the normal pictures, and these are the abnormal pictures. Here you can see the screw has been diagnosed with this technique. how do you manage? Basically, nutritional support is very important. These patients can lose weight pretty quickly. Minerals, vitamins, calories, proteins, these are very important, and accordingly they should be replaced. Medium chain triglycerides, these are the triglycerides which don't require bile salts to get absorbed. So in fat malabsorption, they has a role. And in extreme cases, even patient has to go on parenteral nutrition. Treatment of the causative disease, the specific treatment, the diagnosis should be made and the specific treatment should be given. Gluten-free diet in celiac disease, lactose-free diet in lactose intolerance, protease and lipase supplementation for pancreatic insufficiency, antibiotics for infections, bacterial overgrowth syndrome, and steroids like in Crohn's disease or inflammatory bowel disease. This is a picture, Giardia lamblia life cycle. It's very common if you go to the northern areas and drink stream water. And the epidemics can also occur in urban areas. And this is a person who is drinking Giardia drink. And the syndrome is characterized by diarrhea, flatulence, and especially the flatus is very foul smelling, like a rotten eggs. In that case, a trial of flagyl will save the patient from further investigations. The other thing I want to point out is there is a drug, Orlistat, which is approved by FDA for obesity. Basically what it does is it binds with the pancreatic lipase. So there is no lipase to digest the fat. So this drug can cause malabsorption. And this is a picture showing cereal grains, just for you to remind that the patients who have celiac disease don't use a diet which contains gluten, which is basically wheat, rye, and barley. They can use corn, they can use rice, but as soon as they will use the diet which contains gluten, they will develop the flare-up of their disease. So to summarize, it's very important to think of malabsorption. Patients even presenting with irritable bowel syndrome, they might be having malabsorption. In a patient with abdominal symptoms, chronic diarrhea, weight loss, because prompt diagnosis and treatment can prevent the complications. Thank you very much for your attention, and feel free to ask any questions.